My name is Yahia Al-Tamimi. I'm a consultant neurosurgeon based in the Sheffield Teaching Hospital NHS Trust. I've been a consultant for 6 years. I specialise in skill-based and neuro-oncology and degenerative spine disease. There are a number of causes, depending on the individuals of the different types of conditions. In younger patients, we tend to see acute lumbar disc herniations that are often caused by weaknesses in the capsule of the disc, which allows the disc material into the space where the nerves are, into the spinal canal, and that can cause impingement, pain and weakness in the legs. In older patients, we tend to see a more chronic condition, essentially related to arthritis. We call it degenerative spine disease. And often it's a combination of overgrowth of the facet joints, overgrowth of the ligaments, and again, causing gradual impingement of the neural structures. It depends on the underlying condition. So for acute lumbar disc prolapses, often a conservative approach is adopted as it is self-limiting in the majority of patients over the course of 12 to 18 months. In the vast majority, up to 85 or 90% of cases. However, the pain can be extremely severe, it often is very severe, and patients can either not wait that long or even after 18 months, the pain is still there. So the treatment options are a combination of neuropathic painkillers such as gabapentin or pregabalin, nerve root blocks, which are essentially steroid injections in and around the nerve root that is irritated, causing the leg pain, and that provides temporary relief of leg pain, but ultimately allows the body to heal it naturally. And then the third option, which is often the most effective in terms of an immediate response, is surgical decompression, which does have a 90% success rate at alleviating the leg pain. But for chronic degenerative conditions like lumbar canal stenosis, those changes tend to be long-standing and irreversible, and therefore natural recovery tends to be less likely, and therefore surgical decompression is more likely to be a better option. Lumbar spine disease has a massive impact on patients who are afflicted with it. At one end of the spectrum, there are patients with chronic lower back pain, which can impact on all aspects of daily living. Acute flare-ups of neuropathic pain in the legs can be particularly a problem for patients. It can lead to problems with employment, with retaining a job, in addition to problems with relationships, etc. And we do often see patients quite far down in the line because they've been managed conservatively for so long, and they have really, it has really impacted on their life in a very significant way. Sleep is often affected because pain tends to be experienced more when there are less distracting activities going on, for example, at night time and during sleep. So we do recommend analgesia, and there are different types of tablets that can be taken. For nerve pain, we recommend neuropathic painkillers such as gabapentin or pregabalin. Often amitriptyline is recommended by GPs as a first line because it does tend to work very well at night. One thing to bear in mind regarding neuropathic painkillers is that they do tend to work gradually and build up in the system. So just because a tablet is taken at night time doesn't necessarily mean it'll be more effective at night. But once it's the level of the drug has built up in the body, then it should be effective around the 24-hour clock. Yes, the condition, depending on which condition we're talking about, when it comes to lumbar disc prolapses, as I mentioned before, it does tend to be self-limiting in most patients. So as a general rule, we do say that patients won't necessarily come to harm. However, there are exceptions to this. If the disc is a particularly big disc, causing a lot of compression to the nerve root, there may be progressive numbness and weakness in the foot, which won't necessarily improve with subsequent treatment. And really, it's a case of just balancing those risks of delaying treatment versus early treatment. And then in terms of other risks associated with delays, if you subsequently decompress and treat an area of stenosis that has been chronically compressed for many, many years before, particularly in lumbar canal stenosis, we do tend to find that there is a bit more of a rocky recovery afterwards as well, and the pain can be up and down for several weeks or even several months after surgery, rather than when we catch it relatively earlier.